1.5 years ago. Um, let me show you. This is a 68-year-old lady with diabetes, hypertension, obesity. And she had this very large right kidney stone, 3,500 millimeters square. It seems to be a soft stone. You can see here the bone window scan, the bone windows count, 400 Hanfield units. And you can see the big BMI. So 1.5 years ago, we decided to perform a retrograde approach. And after 90 minutes of a low power laser using a long pulse and 0.8 joules and 15 hertz, there was just dust. Okay, the stone was completely converted to dust in 90 minutes of procedures. So we leave at 4.7 double J. And 4 weeks later, let me show you the low dose CT scan. Do you remember the big volume that we had at the beginning? And here you can see 4 weeks later, we use citrate of potassium. And we thought at that moment that was dust. You can see the bone window. It seems to be dust. So we discussed with the patient and we agreed to wait another 4 weeks. So let me show you the first CT scan, 4 weeks and 8 weeks later. We were right, it was dust. So with the urine flow, the dust goes out. And we just have this small fragment or dust in the lower pole. So we believe that was dust because at the beginning was dust. So we removed the double J everywhere. Everyone was happy, our patient too. But 2 days later, she arrived to the emergency room with a renal colic pain. So that was 1.5 years ago. Today, our reality is completely different. Why? Well, because we have suction. Suction is changing everything. It's changing everything. And today, more and more patients are treated in retrograde fashion, but we can reach a stone-free the first day of the procedure. So today, July 2024, we have patients for shockwave, still shockwave with a low volume stones with predicted values for good results. And in the other hand, we have this big volume stone that we have many of them in Latin America that can be treated with combined approach with the mini SERS. So, but in the middle, we have patient for this and we have patient for fans. And your idea, Ben, was to discuss about what is the best approach in what kind of patients. So, and also with suction, we have changed the settings because when 1.5 years, as I show you, we tried to produce a tiny dust and we put a double J and that was the end. Today, we can leave the patient completely clean in the same procedure and using a bendable ureter access sheet with suction. We don't need dust. We just need small fragments. So maybe we need to choose what is the best laser machines to perform this or to perform fans, and most importantly, with the same machine, what are the settings? Because there are different settings for this that for fans. So suction have changed our behavior, and what we're doing now comparing with two years ago and 1.5 years ago. Let me show you this case. This is another lady with the big stones in the left kidney, and as you can see, here you have the volume 1,600 millimeters. It was a hard stone. And you can see here the hydronephrosis in the lower calyx, because the stone is here in the neck, and also hydronephrosis in the upper calyx, because the stone is blocking the neck of the upper infundibulum. So this patient was with fever. So we decided to put 2 double Js. We were lucky. We can put a double J in the lower pole. We can put a lower J, another double J in the upper pole. And 2 weeks later, with antibiotics, of course, we performed fans. And as you remember, there was a big stone, 1,600 Hanfield unit, very hard stone. And there you can see the venable ureteral access sheet in the renal pelvis. So our setting was in order to produce small fragments. So we were using 2 joules, 10 hertz. And let me show you at the end of the procedure, you can see the field is completely clean all the time. And that's very important. We don't have dust. We can see very well if we have a fragment, and we can suck this kind of fragments. And let me show you at the end of the procedure, after almost 90 minutes of procedure, here is a mistake, it's 87 minutes. But as you can see here, the patient is completely stone-free in the same procedure, in 1 day procedure. Look at the beginning and look at the end. So suction is changing everything. And most patients with this kind of stones can be treated safely in a retrograde fashion. So as I mentioned, when we are doing fans, we need to create small fragments. It's different. With this, we need to produce dust. In both, we have low temperature, or we hope to have a low temperature, low pressure, but the laser settings are different. And maybe the laser machines, if I have all the machines, are different too. But in Latin America, we still have this kind of stones. And in many of our countries, you can find this kind of big stones. So in this part of the world, of course, there is a place still for combined approach. Percutaneous is not death, of course, because you can remove these kind of stones with fans or with this. You need a perc approach in order to remove bigger fragments, and in order to have maybe in 2 or 3 sessions the patients completely stone-free. And in this kind of patients today, we are combining suction in some cases in the perc approach, sometimes in the retrograde approach, and sometimes in both approach. We can discuss later what is the best behavior. But you know, we know very well that the difference between the scope and the inner part of the ureter access sheet should be around 2.5 or 3 French. And that's a problem, because some patients has a narrow ureter, a small ureter. And you can see here, this is a very nice paper from Professor Monga when he was in Cleveland, that some patient has a very small diameter in the ureter. And small diameter, less than 3 millimeters, is related with high-grade lesions. If we try to insert in those cases at 12-14, but if you have a small ureter, you can insert a 10-12. So anatomy, I think that is one of the keys. We need to keep in mind the anatomy, because we need to adapt our instrument to the anatomy. We cannot adapt the anatomy. we need to keep in mind, and we can discuss what are the best laser settings for fans, the best laser settings for this, and of course the stone volume. I believe that we have different patients with different anatomies, different stones volumes, and there is some place for this. There is a place for fans, and of course that in Latin America there is still place for combined approach. Thank you very much.
Thank you, Pablo. Should we take some questions?
Sure.
Anyone, any questions they want to ask? So I have a few questions, practical questions. When you do the fans procedure, what settings do you have the suction and the irrigation pressures? How do you maintain good flow, good balance in these cases?
Okay. We are not using pumps. Our assistant is with the 60 centimeter syringe is giving us suction in order to have a clean vision and in order to have a good suction when we're removing the fragments. And about the settings, we are learning, Ben. I think that if we are using TFL, maybe you need more energy because your peak power is very low. So usually we can use 2 joules and 10 hertz, or maybe 2.5 or 3 joules, because I'm not afraid about temperature because the flow it's very good. And if we are using a long pulse Holbein laser, usually the setting is 1 joule 10 hertz, but it depends about how hard is the stone. But it's a very good question because we are doing fans. We try to produce small fragments. We don't need dust. We just need small fragments so we can go faster.
Yeah. So one thing with the fans sheath is that when it goes into the kidney collapses, which is something we're not used to seeing, I think, with ureteroscopy. It's quite a different technique, isn't it?
Yes, and I think it's a challenge for the assistants because he needs to keep enough fluid in order to avoid that collapse, in order to have a clean vision. I have a pump, but I am not using the pumps because I am not sure about the pressure of the pump. So I think that we need to learn more before to have some conclusions. We are learning. We are still learning what's the best movement inside the kidney, what's the best setting, what's the best flow. What kind of flow do you use usually?
So we normally have just a hanging bag of fluid. But what I found is now, because the pressure is very low in the kidney, you actually need a bit of pressure to maintain a good flow. And I worry less about pressure because the kidney collapses. I know it's going to flow out easily. There's not much resistance to outflow. The other question I was going to ask you about is you said that you still think there's a need for PCNL and combined procedures. Do you have a new stone size that you think is the maximum for these suction procedures to change our ureteroscopy threshold?
Yeah. To be honest, I work in a private hospital. I don't have in my regular day these big stones. Maybe I have 2 or 3 every month. But in the public system, when the people has a poor health systems, they have very big and very large stones. So I think that the limit is not about the volume, it's about the shape, because if you have, as I show you in the last case, all the calyx with stones in an infected patient, I think that the combined approach is the best. If you have, as the second case, very good calyx necks, and the stone is in the, you have a big stones in the kidney, but you can reach easily to those calyx in a retrograde approach. In our institution, most of these kind of stores are treated with fans.
Which brand of fan did Pablo use in his video?
You may not. I'll say the question again, Pablo. So the question is, what sheath did you use? Which brand? The fans.
We have two in Argentina. We have the 1012 Seplo one, and it's arriving the Clear Petria. We have two brands in Argentina, and we don't have still this in Argentina available. I think that in the next months will be available. I just did a couple of cases in Peru and in Uruguay, but I don't have this available in Argentina yet.
And do you use the 1012 as your standard size, or do you use other sizes?
Yes. We are the standard one is the 1012 because we are using the 7.5 scope.
Yeah. So what's the best combination?
Yeah.
1012 and 7.5.
You think this is the best? Yeah.
Okay. I think that you need, yes,
That's
you need 3 French in order to have good suction.
So the suction is constant or unrequired, or?
So how do you develop your suction, Pablo? What's generating the suction?
Oh, it's connecting to the suction in the room. So usually during the procedure where we are creating fragments, we just leave open the lateral hole and we block it to remove the fragments at the end when we are removing the scope.
And what pressure do you have on the suction? How much suction?
Honestly, I don't know. I'm just connecting to the general suction. Do you know your suction?
It comes in different levels, I think, low, medium, and high. And I don't think anyone knows exactly what it's generating.
But you clinically, you can see you use, I tell my nurse,
more
put it on the middle, and then usually I say turn it down a bit.
Yeah. I fully agree with that. You just need to avoid the collapse. So it's a balance between the suction and the infusion.
We have another question. Hang on a second, Pablo.
When
aspirating,
does he remove the hole completely or partly?
So there's a question about the technique of removing the fragments with a fans sheath.
Yes.
Do you completely close the vent, or do you leave it partly open? How do you control the suction?
I think that that's the most important part. There is the infusion. So we need the assistant with fluid, and also usually we block completely the lateral hole in order to have the maximal suction at that moment.
Is it any place to remove the scope and continue suction? Potentially you can fit bigger fragments.
So this is what we're talking about. So the fragments in the kidney, you can draw them down the sheath like a basket using the suction. So you pull the scope back to the split, the bifurcation in the sheath, and the particles of stone will go down the tube, and then you put the scope back in again, and then if you need to break up more stone, then pull the scope back. So it's like basketing, but using suction as the retrieval rather than a basket.
I have a question for you. Are you still using ureteral access sheet without suction?
Yeah.
In what cases?
We can do suction to the sheath, and we can do suction to the actual scope. Between what do you think? I mean, we have experience with both the way.
So the question, Pablo, just to repeat it, is obviously there's this debate between suction through the scope versus suction through the sheath. Where do you think the future is in terms of which technique would you use in preference, and would there be some cases you would use one and not the other?
Yeah. Well, if you have a patient with a small stone that, for example, fails to shockwave, a 200, 300 millimeter square stone in the middle calyx in a patient without stent, I think that this is the best. So we just need to put the 7.5 to have low pressure because you are suction all the time, and you need to dust the stone with low energy and with the long pulse. So in the other side, if you have a 2000 millimeter square stone, for example, a big stone in the renal pelvis, I think the fans is the best for those patients. So I think that we are learning, and we are in the middle of a big change. So our conclusions are for today. Maybe in 6 months the conclusion will be different, but I think that today we have patients that are better candidates for this small volume, small ureters, non-prostated patients, and we have good patients for fans, pre-stented patients, big volume stones, infected stones, and also you need to consider what are the settings that you are using for the lasers. Again, if you are doing fans, you need to create small fragments. You can go quicker, and your setting, of course, are different. Maybe you need to rise your energy. You're not afraid about the temperature. So I think that we are still learning what is the best way to use the new tools.
Excellent.
I have a last question, or well,
Sure.
so do you think that there is a space for pre-stenting for this? Because do you actively pre-stent patients for the sheet? Because I have patients where I just cannot put it above the UPJ, or it's dangerous, or I don't know. Are you actively pre-stenting patients for fans?
Yeah, no, we are not actively pre-stented. Our common approach is to put a wire to try to perform a semi-rigid ureteroscopy to take a look of the ureter and to produce a passive dilation. And after that, try to insert the 10-12 ureter access sheet. If we have a big stone and a big volume stone, and we can reach to insert the ureteral access sheet, you would put a double J and be back 2 weeks later. That's our common approach. But we do not perform pre-stating if a patient is not infected. If you have an infected patient, it's a special patient maybe, and a big volume infection, a big volume, maybe that's the patient for pre-stenting.
So when let's say it's 1 hour procedure, how many withdrawals roughly would be? Is it you say you need to save, but you know what would be the kind of how many times you would do it?
Yeah, it's hard to say. I don't have the number. I would say all the access that you need to leave the patient stone free, but I don't know. I remember the paper from Peggy Pearl, and she talked about 50 go in and go back. So I honestly I don't have those number, but as much as you need to leave the patient stone free. I don't have the number. Ben, do you have a number?
I don't. I think the difference is when you're doing fans, as you're lasering, the dust disappears, and every time you go back in and do a bit more lasering, part of the stone comes out as dust, and some fragments are there. So it sort of gets faster and faster as you go through the case. And I don't think you remove all of the stone by suctioning big fragments. Usually there's some comes by dust and some comes by fragment.
It's a mix. It's a mix.
Yeah.
Well, yeah. As we know, it's kind of not to overdo it, yeah, let's say, because you say, okay, I see some practice, I will draw it, and I'm doing too frequently. So I wanted kind of,
Yeah. So, you know, I think it would be difficult to say, and sometimes when you draw you have 3 or 4 fragments on the end. Other times you may just have 1. And it's a technique that we're all learning and getting better at. That balance between the inflow, the higher pressure that you need in the kidney to push the bits of stone out to the lower pressure.
I maintain the access sheet was on the just above the PUJ, yeah.
No, access sheet is in the case where the stone is.
Yeah, it needs to be very close to the stone.
Needs to be. Then
Okay, so it's actually flexible.
Very flexible.
So what you go with the scope, and then you go with the page.
The higher, it helps fragment. And sometimes you might get 2 or 3 fragments, sometimes you get 1 fragment, sometimes on the way out, you drop.
That's really good part of that access. Got the color.
Yeah, that's vital. Yeah.
I mean, say because it's quite new that we're still learning, we will get more efficient at it, but it can be frustrating, I say.
Yeah, so you, like Oliver said, that's the end of the
Actually, cool. Situations where you start off and think that you're going to use this rather than that.
So Pablo, a question from Ollie Wiseman. Are there some cases when you start off thinking you're going to use this rather than go to fans?
Mhm. Sorry, what's the patient for this?
This is fun.
No.
So you would select, you mean, when would he select, when would you start the case and say, this is a case I'm going to use this? Which cases would you start with this?
Okay. Low volume, it means less than 300 millimeters square. Non-prestated patients. I think that's the right patient for this.
Yeah, I think the first case that you showed where the stone was all in dust.
Yes.
It's sometimes difficult to predict which stones are going to behave like that.
Yeah. And
that's
I think
probably
it's
probably the minority that do that. Most of them, break into fragments, and you're left with some fragments at the end.
Yes. I have a question for you. What's the time limit that you are using now? Because we are still using 90 minutes, but I think that maybe that's going to change. But we are still using 90 minutes. Are you using the same? What's your infection rates after fans or after this? Do you have numbers about that?
No, for me, it's still too soon, but I think you're right. The theory is that if you've got high flow, low pressure, then you're going to worry less about pilovenous backflow and potentially less sepsis. But there's probably an issue just from being inside the kidney for over an hour and a half. I think there's probably going to be a limit to how long you can stay in there, just constantly washing the kidney out. So, Ollie.
I think the worry also, Pablo, maybe is the effect on the ureter of having an access sheet or a scope in the ureter for more than an hour or more than an hour and a half from the point of view of ischemia and strictures. So I don't think that we really know that, and I'd be worried about going longer, I think. Yeah.
Yeah. Depends on the ureter, doesn't it? I mean, Any more questions?
mileage this scope through a fan's sheath. They have both.
So Jake Patterson wants to know if he can double the cost of his procedure by using a disc scope and a fan sheath. So he says, is there any benefit to having disc and fans together?
I don't think so. I hate it. You have the right patient for this and the right patient for fans. But we are creating knowledge because we are creating data, and we are in the middle of something, you know. But today, I think there are different patients that can be benefits with both approach.
Yeah, brilliant. Thank you so much for joining us at 5 o'clock in the morning. I think you performed extremely well for this time of day. And yeah, really great to have you join the meeting and show us your experience with these suction devices, which I think are changing our practice globally and very rapidly, actually. So it's great to have your contribution. So thank you very much. And hopefully another time you'll come in person.
Yeah, I will be glad. And thank you so much for inviting me. Have a good day.
Thank you.
Fans with deep sheet, yeah, this would be called fans.
That's fans, yeah. It's flexible and navigable sheet.
And this is clear petrol, this is different.
There are two, there are a number of
Clear petrol.
fans.
The one new.
Okay, so they call it clear petrol. They're only one not. And then people feel kind of reluctant with it.
And that's the PUJ, and that's no good from the lower pole. But now that you navigate it into the lower pole and be next to the fragment, that will encourage the fragment to now you can cover now as well.
Yeah. How about putting for better washing? If you put in this thing kind of axis catheter, which is free French, to get more flush and then suction. You understand the concept?
Totally understand the concept. And that's the problem I think at the moment is trying to balance the fact that you need to have higher pressure in the kidney to flush the bits out. So you need to always constant flow to the fragment of the
But this way you can the free French.
yeah, I think it's going to get so I think give enough space to put the through as well. But what you have to do, I flow through your scope as you're sucking out. So you're sucking out through your sheet. You've got high rate in your thing. No, you're going to do
But channel.
that the direct factors back.
Can you? I can use this information.
For the situation you withdraw your soul, you've got only suction.
You've got flow through
With the same channel.
You put that in here. Present it again.
Yeah, but then so what we say, the same. You go flow in and flow out. Yeah.
It's in the same thing, like you have this vortex. From a high pressure area to a lower.
The time much longer, you can't say this is the same effect.
No, I agree. I think it is harder because the tunnel's longer. And I think that part of the way, along as you're withdrawing your state, you can lose your stones because you've got that pressure pushing them out. So I totally agree. I mean, it's not the easiest technique, and I think lots of us are still learning it. And there are things that.
But what he showed is so many fragments that after DCNR, it's amazing. The container with the fragment.
Only what problems that you play with them and then get different. Not the children is good. They're not good stones to treat. Yeah. This is the agent with the
Is it?
Residual fragments is concerned.
So it's the bottom. I think the problem with the suction, I think the suction now is huge because it's our long tube. So it's going to get a load of matrix staying there, but it's got dust within it. Separate the matrix with laser. So it's going to change the role of that.
Community, you're saying they try to divide, get the pressure to get the pregnant flowing out.
So, people who are using it regularly work in. Yeah, and so I'm worried that, like you do, that might be causing too much pressure in the kidney.
But you've got function as well. That is what I've done. Basically, it does a wealth of experience before, but without it, everything is collapsed. There's no depression kidney is low. But it doesn't work. You need to fill the kidney up to see it. Right? But depression too. God, so
It's
the year ago. The glass because you're breaking the straight up see it's finance coming pretty good. The same thing. There is a bit of something for all. Yeah.
Okay, so thank you again for the invitation. So this is a very interesting topic, and especially to talk about after what we just mentioned on these and fans and how small the fragment is and how difficult the fragment is to get those fragments out, and what to do if we leave those fragments in the kidney. So how do we define stone-free in 2024? And this is a more complex, for me, this is a more complex question because it comes with a bunch of other questions regarding stone treatment. For example, what is treatment success? Is a successful treatment a patient that is completely stone-free? It depends on the patient, actually. It's better to get the patient a good quality of life rather than a complete stone-free. So do we need to operate our patients 2 or 3 times in order to get them stone-free? What is stone-free? We haven't had a consensus. We don't have a consensus between us also. And if we can accept those small residual fragments. So the problem is that this is not oncology. We are more refined, we're more sophisticated than oncology. You know, we have a even more complex specialty. If you have a tumor, they remove the kidney. If you have a tumor, they remove the bladder, and that's it. We don't. It depends. There's a lot of there's a lot of let's say situations and a lot of variables that makes our specialty let's say not difficult, but challenged. Exactly. You have guys grade 1 is a lower pole stone. You have a very good stone-free up to 90%, but it's also depends on location. You move that very stone to the upper pole, it's grade 2, the stone-free rate drops. You have 2 of those stones in the kidney, the stone-free rate drops even more, grade 3. Or you have a big volume, and the stone and the stone-free rate will drop. So it depends on a lot of variables, and that's the real problem for us. So it's not the same to have a patient like in the right image. I will hopefully get this patient completely stone-free. I can count the stones. It will be awful not to leave this patient completely stone-free. But in the patient in the left, maybe if I don't leave the patient completely stone-free in 1 or even 2 sessions, I wouldn't feel that I did a bad job eventually. You know, it's not the same, for example, this case. It's very difficult to have this patient stone-free. So maybe just removing the stones in the pelvis is a good initial strategy to give the patient some quality of life, and so his or her kidney is fine. Another case is not the same to have these two kidneys on the right. I will leave the patient with the transplant kidney completely stone-free, but the other kidney, look, this is I don't think a stone-free patient in this kidney will be necessary. Or there's also variability in the same patient. We don't have two kidneys which are exactly the same. We see that with the pressure systems, with the ureteroscopes with pressure systems. We go to one kidney, we measure one pressure, we go to the other kidney, the pressure is completely different because the anatomies are completely different. It's not the same patient. I would leave a 2 millimeter residual fragment in this lower pole, but I wouldn't leave a 2 millimeter residual fragment in this same patient. So it's very variable. So this makes the definitions and what is a treatment, a success, kind of we have to open for discussion. So stone treatment is not the same as treatment success, but of course, stone-free status is one of the main parameters of surgical success. And this comes with another question: how we do define stone-free? What is dust? We said, no, you have to dust the stone. You can leave a little bit of dust or you can remove dust. What is dust? What is clinically insignificant residual fragments? We don't know this. And how we evaluate residual fragments. So there's no consensus on the literature. But now we're getting we know what is the best, but we don't do it always because of maybe the system. I cannot do CT scan to every patient that I treat. At least in my system in Spain, it's very difficult. And if I clearly see the stone in a KUB, maybe a KUB it's enough for me afterwards with ultrasound. But now, for example, the Journal of Endourology is not accepting studies that don't have stone-free rates measured with CT scan. Yeah, you know, this is changing, and what we know and what is real is that the only reliable source to see if a patient is stone-free really it's the CT scan. So this is one of the first conclusions, and ideally after 1 month of treatment. So what are the definitions of stone-free? The first thing is, what is dust? So dust has been the most commonly accepted dust definition are stones of less than 250 microns. This is an in vitro. These all come from in vitro studies because those are the stones those are the particles that may be easier for the patient to clear with the normal urine flow, and that can be aspirated through a 3.6 French channel, working channel. So this is why the definition is 250. This may change. And how do you measure that? We don't have any instrument to see, oh, I just left dust. It's very difficult. We did a survey with the EAU, and we asked a lot of urologists, what is clinically insignificant residual fragments? And look at the answers. 20% for 4 millimeters, 20% 3 millimeters, 20% 2 millimeters. We don't know what we are talking about. So there's no consensus of what clinically insignificant residual fragments is. So this is everything larger than dust, I guess. So if you grab all the literature, some people accept residual fragments of more than 4 millimeters in their studies, 4 or 5. But they have 28% retreatments. One third of the patients will need treatment in the following year, and 9% will have a spontaneous exposure rate. So it's very low. So based on this, this is not a good cutoff for clinically insignificant residual fragments. So the EAU guidelines, for example, do not recommend retreat patients with 4 mm stones that we left after our surgeries. There's other definitions between 2 and 4 among the studies, and this is what is more or less accepted. But it's really a 4 mm stone or less than 4 mm stone clinically insignificant. You still have 30% retreatment, 46% spontaneous expulsion, so better than more than 4 mm, and 34% progression at 3 years. Still, the EAU guidelines accept residual fragments of less than 4 mm. You may leave them. Yeah. Of course, you have to tell your patients that it may come with some problems, but you may leave them. There's also some studies with a cutoff of 2 mm. You have less problems with 2 mm than 4, of course. So 2 mm now it's kind of an accepted clinically insignificant residual fragment. But there is even definitions of smaller residual fragments. So in 2013, they published this paper in the journal Urology, saying that, well, their cutoff was 1 mm, and they called this the 0 fragment status. So there's even that other definitions. Let's say the cutoff for clinically insignificant residual fragments of 2 mm is the most commonly accepted. But the ultimate definition, the true definition of stone-free, is the 0 fragment rate in CT. So the conclusion is that stone-free is the absence of stones. It doesn't matter. You can call it whatever you want, but stone-free is the absence of stone. If you can accept larger fragments in the kidney, larger or smaller, it's good, it's okay, it's up to you. But a true stone-free, it's the absence of stone, just to be clear. There's also new definitions coming in the literature. For example, this volumetric stone-free rate that just tells you not to measure your residuals with diameter, but with volume, just to counsel the patient even better. A 2 mm residual fragment could be a 2 by 1 by 1 or a 2 by 2 by 2. It's 4 times larger, same 2 mm residual fragment. So you can counsel the patient better on which treatment they need, or if they need treatments or not. So those are the definition. And what are the best management strategies for this if you leave clinically insignificant or small residual fragments? So if you leave clinically insignificant residual fragments, I always counsel the patient. I try not to over-treatment, and if it's less than 4 mm, especially less than 2 mm, I try to treat them as asymptomatic stones. This is my personal approach because my waiting list is too big. So I try to treat them as asymptomatic stones, or like a wait and see. If they move, they go to the pelvis, or they have symptoms, I treat them exactly as the EAU guidelines states. But there's also high-risk patients, which can be managed or have to be managed in a completely different manner. You see this case? I treated this patient with flexible ureteroscopy. I was very happy with the post-op KUB. You don't see it, but there's a really, really small, insignificant stone there. I said, no, this is just dust. This is nothing. Don't worry. 1 month later, it was okay. 9 months later, the patient had this. So high-risk patient cannot be treated as other patient. This patient had a bruchite stone. So in these high-risk patients, we need to give the patient that 0 fragment status. So no stones, no dust whatsoever. Struvite stones, cystine stones, you can recognize them because they are like orange, shiny. They smell like sulfur. You've seen them. you have these bubbles with smoke inside because their cystine is insoluble. So those kind of patients where you in the surgery just know that it's a cystine stone, you have to give it all, and so this patient has a 0 fragment status. So it's this white, pale yellow stone that it's really hard to the laser treatment. When you see this kind of stone, you have to remove all the stone because this patient will have the fate of the patient that I just showed you, even if it's the smallest, tiniest fragment that you leave, or it's struvite stones. This is also the high risk patient, because this patient, if you don't acidify the urine and you leave a small fragment, it may be a staghorn in 1 year time or 6 months. So you see these onion rings that they are coming. So this patient had a struvite stone, even if it was the similar case as the first ones that I showed you, when we remove only the pelvic stones. In this patient, we had to remove everything because we need this patient to be completely stone free. I will say mid-high risk patient are uric acid stone. In these patients, I always give potassium citrate afterwards to help them remain stone free as much as possible. Even if you have a stone, even if you leave some fragments, it may dissolute. You see, this is a patient treated with potassium citrate. The stone just cleared with medication. I have a sense that if you treat the patient, maybe the stones are more exposed to the pH or the medication, and they are treated better in that sense, even if you leave some dust. That's what I believe, or my sense. And of course, to all the patients, I give dietary measures, pH modification medication to increase those stone-free rates and to help them avoid any other problem. And also, when you leave, finally, this is my last slide. When you leave the patient with some residual fragment, I always, let's say, talk to the patient to see what it's in his or her best interest. Sometimes the patients are saying, look, I'm great, I don't have any pain, I don't need more surgeries. If it comes, it will come. Even if it's in 5 years, I'll be 5 years very happy, so don't perform the surgery, or the other way around. So there's always the patient's preference that it's very important in this situation. So to conclude, stone-free is the absence of stone. With CT scan, the only reliable evaluation. You may accept stones of less than 4 millimeters, better, less than 2 millimeters. And not all the patients are the same in this case. And that's it. Thank you very much.
Questions?
You said about methionine in the white stone. What is your experience? I haven't got any experience about it.
So we give them methionine, 500 milligrams 3 times a day, to acidify the stone, to avoid recurrences. So this is something that we do. For its it's very difficult. The compliance with medication in stones is really low, I found. There's some patients with uric acid stones or cystine stones that are more compliant because they have more problems, but the compliance is very low.
Is it strict? Some citrate, so you've got once a day versus 3 times a day, miserable drink.
What do you mean? In terms of no, it's the same. Yeah, it's the same.
Further on, I get with this. I've realised that medicine is an art, not a science. And we talk about taking our kidneys and some curing cancers. And if I was to ask you a question, so you're going to cure somebody of their stone, what is your definition of cure?
No, that's the thing about the compliance, that this is not a cure.
But CR is this is not cured. When I ask patients about whether they're cured of the disease,
Okay,
I ask them, what do you expect to cure?
well,
They say it doesn't come back. I ask them how long for, and they say they have no answer. So the answer is for the rest of their life.
mhm,
So the issue that I have with the CRF definition that we have here, EU guidance, depending on the success of treatment, but actually if the patient is going to die within 3 months of congestive cardiac failure, then stagnant on stone is irrelevant. So actually it's insignificant. So it's more
Yeah.
about redefining, because I know a lot of people I follow up with small stones, and then we have a lot of locums that come through and they discharge them. And they just say these are too small to follow up because they've had no spontaneous event in 3 years.
mhm,
So I think somehow, maybe one day, when we get a definition, or a proper definition, we'll actually put a time scale in there. If I can say, look, I don't want treatment because I've got some sort of horrible conditions.
okay. So what is a successful treatment in that patient? Maybe just place a double J. That's
Or not.
or not. Yeah. If they have a urethral stone, leave the kidney alone and just remove this urethral stone, and that's successful. That's it. So it's
Stone disease is a chronic disease. I mean, if you get one stone, your risk of another stone within 5 years is
But what if
pretty
we
high.
want in 5 years?
Yeah, but most stone formulas, I mean, the average age of your first stone is 49 in this country. So most people are going to live more than 5 years with their stone history and disease. Yes, if you see a 90-year-old with a cycle, you're not going to jump in with a BCNR, but the majority of our stone formers are middle-aged and with anything. So the question is, how often do you intervene? And the question I was going to ask us about was around follow-up, because the EAU guidance now has a lot of follow-up, and practically we can't offer that follow-up regimen in this system. How often do you think is reasonable to follow up patients with stones, and what are you looking for? I mean, it's not like active surveillance for prostate cancer where you're looking for a cancer. What are we hoping to achieve by following?
My personal approach is high-risk patients. I follow them for like 16 stone patients, for example, for life, or a very complex anatomy. But if I have a calcium oxalate monohydrate stone, that it's asymptomatic, like a 4 millimeter stone, that it's a 5 millimeter stone, asymptomatic for 5 years, I discharge it. Yeah, 5. That's my. Yeah, with anemia, yes. Mm. Yeah, exactly. I just
So it's less than 5 minutes. It's updated GPs, I don't want to see that patient. And it's the same symptomatic growth, you can do some monitoring in primary care and ultrasound every 3 years. If it gets bigger, send them in. But then why should I then see them back in my clinic? And I guess you could argue that a fragment after you've treated someone is a different entity to a de novo stone that might still be a pillar. So they behave differently, and the natural history of those fragments is different after PCNL than it is after conservative management with internally bound stones. But I think we certainly can't do anything like the EU guidelines.
But also scale of population of, I mean, as it's been done for in America for colorectal screening, they use a CT scan everyone's abdomen's age 50 or 60. About 8% of the population are carrying a stone at any given time. So are we just then monitoring a population of people who never come to see us clinically? Well, don't worry. But we can't predict, so we just do a lot of scans.
I tell them I'm doing a symptomatic follow-up. So just don't come back. And if you have symptoms, just knock on the door. Yeah, exactly.
well. It's 170, 5 me. It's okay, say some. Yep.
You're not journalistically kind of patient what we're going to do or not going to do. If you had a dialogue with that patient that risks of conservative residuals, I wouldn't leave a 5mm stone after treating 10mm stone and they are going to discharge you. This is what 2mm bit that they had a horrible time with stent and didn't like ureteroscopy or work for 3 weeks. And actually, from a medical legal point of view, operate on that patient could be strong arm and means having no fragment.
Stay forward and everything, stay all the way. That's the point.
Yeah, they require everybody to avoid more risks.
Esteban, you talk about the high-risk patients, the importance of getting them stone-free, Relive stones, brush-like stones. How do you do that practically? So, what extra measures would you take in those compared to somebody who's got a dihydrate stone or a monohydrate?
So nowadays I'll try to use, for example, fans. Yeah. And those are the patients that I don't, then even if it's the smallest fragment, I encourage the patient to undergo another surgery, for example. Just, yeah, those are the.
So the threshold for reoperating is much lower.
Follow up, but as you said, see, CT follow up is a definitive way of telling any this significant fragments, but I don't follow the CT anymore. Many of us may not, which we
I don't know
in previous time, and but comparing the CT and ultrasound so much disparity is so much variable. So exaggerate the things or underestimate the things, you may can't rely at all on others, but still we do mainly making sure that
Yes.
organ impulses are obstruction. But how to use the ultrasound as a follow-up when you can't be sure about the size, number, and whatever it is, and we don't want to do CT, to look at radiation to follow them up, and the people and all. So it's difficult to follow.
Yeah, this is
imaging follow-up and frequency of imaging also. I don't know any sort of evidence there to do this way or that way, or experience how that's true.
So in more sense, see where the CT probably less radiation than the X-ray KEV. I think with AI and those DD scanner, you start DDing every single patient, every single time, will never be able to. So I think, but the radiation rate is much lower.
Can ask radiology for ultra.
Yeah, so they have the protocol. We do all our follow-up CTs. And we do follow-up CTs.
But I think we're using this as an excuse that we can't do this CT and we can do it's stone free, we can't change. Because they are operating here, they put CT incorporated in the thing, so potentially you can do the CT at the end of the procedure, no problem. We've got like this in paper, somehow we never use it. So because you say, okay, well, that's stone free, well, we're not doing CT because there is a cure and there is no indication, and that's the saying, the dose is low, so potentially, really, the end of your procedure, you put the arm in and
although you need
to wait some time.
Yeah, exactly.
That's
Right.
another much 1 month.
We've got pretty sure the clip actors on the show. Zoom. Wait, no one knows what we've got. What's it anyway? I believe for me you have to should be as such and the point the sheet slipped back and you need it really close to the stone. And it's not even very bad. It's quite different. It gets very wet after that flow. But if you're doing the fragment, you don't need like a bend. Just gonna break it. You get that. But then you the other, you basically coming out of so I'm getting you a high flow out. So the dust doesn't really need it. Yeah. And the suction is the high for pulling the bits out. Everything is dead in the sheet. Just come to the swimming. Yeah, that's one of that job. Like the first job. It's bigger. It's just a few minutes ago. Bigger. Not bigger. Not. Yeah, you'll have to
Sorry, guys. Can I, do you have the Wi-Fi access? Apparently my video getting like this possible. What do you want to do there? I think you're yeah, you want to hotspot onto me? Yeah. I'm gonna do it. That's a good question.
Just realised connect to my hotspot, and I don't know what the password is. Hang on, if I pair with you. What do you need to set the internet for the
Status, the flight status.
okay, they can do it from here. And then
Okay, cool. Thank you.
sorry. Esteban's flight's been cancelled. BA as well. BA. There's a flight earlier and a flight later, but sort of annoying, isn't it?